Should we go ahead and get rolling?
So I think they'll trickle in, but
They'll trickle? Okay.
it's good. Yeah, we can get started.
Okay. And my understanding is we need to be out of here by 1, right?
Yeah, some people are gonna leave probably by 12:40, 12:45 because they have to run over to get their clinics.
Okay. Sounds good. Sounds good. So I am delighted to be here. Want to thank Dr. Thomas and her team for, I understand, finagling some grant money to make this happen. And I understand it's through the State Department of Health and CDC funding to talk about some things. Today we're going to be talking about squirrels. Has anyone ever seen a squirrel before? Okay. Jonathan's like, nope, haven't seen those. So the topic that I was asked to present on was a resident level discussion about ADHD safe prescribing. I understand that there are a number of adults coming to clinic who are interested in finding out a little bit more about that. And depending on what rotation or what service you're on, you might see some of that. I'm doing a similar talk at 5 o'clock today for the med student level. And that one actually has more osteopathic considerations involved. So this one is more business as usual. So really fun for me to be in Kirksville. The last time that I was here was actually 14 years ago when my BMI was considerably better. And that's outside of Baldwin Hall and the Truman State campus. I'm also a Truman State graduate, so I have a lot of heart for this part of the world. Hello, welcome. So if you want a copy of the slides that I'm going to be talking about today, you're welcome to scan the QR code. I also have the website. I created a page specifically for the slides. The slides on mobile, if you're on your computer, you'll see the slides display on the page. If you're on mobile, there's like small little dark download buttons that you'll be able to see. So I'll give folks a second. If you are into QR codes, you can take a look at that. And you'll see there's 2 slide sets on there. One is this talk, and then one is the 5 p.m. Med student talk, which is going to be happening somewhere in Kirksville, Missouri. That's my understanding. So, and hello, welcome, Brett. All right. I'm happy to stop and take questions at any point. If we don't make it through the slides, it's not the end of the world. I specifically put the slide set together so that they can be a reference to you for your own prescribing and your own interest in studying. So there's a bunch of stuff toward the end about prescribing, titration schedules, all these different sort of very brainy things that may or may not speak to you, but they are there for a reference if you want, and a little bit more condensed than something like up to date. So I've got a case here for you. This might be a patient that you know. It's a 33-year-old male, no past medical history, presenting to a clinic with chief complaint of difficulty concentrating. You don't actually have to write anything down because it's lunchtime and that country fried steak smells just like it did 15 years ago. So I wanted to ask you to give me some things that might be on your differential diagnosis for this patient. Insomnia, sleep affecting concentration, good. Depression, very good, Ming, thank you. OSA, yeah. Yeah, OSA, as in my work as a psychiatrist, I diagnose a ton of OSA that somehow gets missed. I get patients referred to me for ADHD, depression, sleep disturbances, but somehow they missed that sleep study. Very good. Anything else? That's 3. Stress, yeah. Anyone have trouble concentrating when you're stressed? Like this morning? Yeah? All right. Friends on the couch section, anything in your differential for this? Thyroid, safe, right? Thyroid and lupus, you can always say those, and those are bound to be somewhere in the differential. Good, okay. Yeah, so some of the different things that came up as I was thinking about this is, of course, you know, could possibly even be like seasonal allergies, right? Or the effects of allergy medications. How many patients are taking something that affects their histamine throughout the day? Hearing and vision disorders, genetic disorders, seizure disorders, anything endocrine, not just thyroid, lead poisoning, if you're taking the Comlex anytime soon, maybe. Not saying that I write for NBOME or anything like that, just right now. Hypoxia, delirium, drugs of abuse, any type of central nervous system pathology, or even infectious things, right? We remember going through, did you guys get like the Vindicate mnemonic or acronym or whatever it is to come up with differential diagnoses, right? Concentration is a pretty broad possibility for all the different things it could be. Now, a couple different questions for you. We'll do this by voting. I didn't go through the effort of creating like a poll EV because I knew we'd be working on our country fried steak. I didn't want to interrupt that. So which of the following adverse effects are associated perhaps with atomoxetine in adults. I'll give you a second to read through those. And we'll take them backwards. How many think it's none of the above? Who doesn't know what atomoxetine is? Start there. Okay. Let me help you out a little bit there. So atomoxetine, the brand name on it is Strattera, and it is the first non-stimulant medication that's FDA approved for treatment of ADHD. I'll tell you a little bit more about it here in a second. So that's atomoxetine or Strattera. So I don't think I got any votes for none of the above. How about hypotension? Bradycardia? Stevens-Johnson's? Sexual side effects? Yeah, okay. So we got a few votes for that. And who abstains from voting? I like that, right? I like that. Hello. So very good. So one of the ways to think about atomoxetine, if you see it come up on a COMLEX or USMLE or specialty exam near you, is it is a failed antidepressant. What happened was they took bupropion or Wellbutrin, which is a norepinephrine dopamine reuptake inhibitor, said we want to make a medicine that's kind of like that. Let's just make a norepinephrine reuptake inhibitor. Turned out it didn't work too well for depression. Wasn't a great antidepressant. Helped a little bit with concentration. Drug company said, we've already invested so much in this. Let's just carry it through and get an indication for concentration. So when we think about atomoxetine, it's a lot like antidepressants, which we know are also heavily associated with sexual side effects, not just on board questions, but also in our patients. Very good. Next question for you. Diagnosis of ADHD in adults must include which of the following? I'll give you a second to take a look at the options there. Who would say a retrospective history of ADHD symptoms before the age of 12? All right, I like that. History of school failure, motor vehicle accidents, multiple failed marriages, substance abuse. Now, the interesting thing is, are these other things B through E? So the correct answer is A for the diagnosis. But are these other things also common in patients who have a diagnosis of ADHD? Absolutely. Just not required for the diagnosis, but important to think about. Let's talk a little bit about bupropion. Which about bupropion is true? Let's take a look at those answer choices. Okay. Welcome, new friends. Who thinks it's all of the above? Yeah. We'll pause there because it is all of the above. Bupropion, again, it's an antidepressant medicine that has nothing to do with serotonin. It's all norepinephrine and dopamine reuptake inhibition. And because of that, it has all of these interesting things that one might need to know about it. I'm going to skip that one. But I'm going to take a look at this one, which is, which of the listed disorders is the most common comorbidity with ADHD in children? Give you a second to look at those. And I see Cade's on Zoom. Hello, Cade. And anyone else on Zoom who I can't see? Okay. Who thinks it's a learning disorder in math? Learning disorder in expressive language. Oppositional defiant disorder. You guys are so good at this. Separation anxiety disorder and gender identity. Okay. Similar question. Are these other conditions commonly comorbid with it? Absolutely. Right, but not the most common. So today what I'm going to try to get through in the next little bit of time is talking about ADHD and the way that it's clinically diagnosed in youth and adults and how that's a little bit different. Talking about how different subtypes have some different presentations. And then we might get to talk a little bit about the pharmacology and those things later. If not, as I mentioned, they're in my slides, but I'll try to get you some best practices. What's your access to psychiatry like here, especially for kids? Like, is that a referral you guys can actually get placed? I see some giggles. No?
Nope. Good luck.
Good luck, okay. Okay. So after the presentation, if you have a patient, of whatever age and you're stuck on the case, give me a call too. I'm happy to talk with you guys. And I think a large part of what we do is teaching and helping out and trying to make those things happen. I'm not going to medicate the person for you, but I'll at least help you figure out, what to do and that sort of thing. In case this talk doesn't answer all the questions for you. So let's talk about the clinical characteristics. And this is something, these are sort of the criteria that you will need to know. DSM's got pages and pages upon this. However, the things that you would need to know that will get you through most of the multiple choice questions are that it's often a combination of inattention, hyperactivity, and or impulsivity that begins in childhood, often persists into adult years. The functional impairment, we remember from our psych exams, is the key thing, right? It has to cause functional impairment. Person can't just be squirrely. It has to actually cause some type of problems. And I think that this is the kicker, especially as we're looking at diagnoses in adults, is that we're really trying to get as much perspective about historic diagnoses as possible. So if you have somebody who's been really without any functional impairment throughout their whole life, they make it to third year of med school, and they're on this really tough surgery rotation at the Northeast Regional Medical Center. And they notice that that's when they start struggling. The hours are really tough for them. They're kind of falling asleep as they're suturing. Do they have ADHD? Probably not. So I think that that's one of the key things. It can be hard to get that information, but one of the important things to think about. So this is not a picture of AT still. This is William James, a famous psychologist who described in 1890 a type of character in which impulses seem to discharge so promptly into movements that inhibitions get no time to arise. These are the daredevil and mercurial temperaments, overflowing with animation and fizzling with talk. Does it sound like anybody's assessment statement on your notes? I love the way that writing, I feel like we've lost something. So of course, issues with concentration are things that have been around forever. We can think about the ways that our modern environments have changed that for us. How many of our great-grandparents, for example, have spent as much time in classrooms as we have, versus perhaps learning about life different ways. So it might be a factor of our environment, but certainly 1890, we had this come up. In the 1960s was one of the first times that we saw it kind of consistently defined as the hyperkinetic syndrome of childhood. ADD came along in the great year of 1980. And then all the way to 2013, I haven't updated this for DSM-5 text revision, but in 2013, DSM-5 changed a little bit more, saying the onset had to be at or before age 12 and present in 2 or more settings. Now, it affects a large percentage of the population. Who would say that if we're looking at school-age children, that it affects 90% or more, 80% or more, 70, 60, 50, 40% or more? Wow, might seem like it sometimes, especially for those of us who have kids, my goodness. 30% or more, 20% or more, 10% or more, 5% or more. Excellent. I love folks who abstains from voting. Yeah. All right. Very good. I am all about when I was a student doctor and a resident, I was all about the abstentions. I'm like, I'm tired. You guys figure this out. So most of the time when we look at studies, it is kind of actually, it's a significant percentage, right? So if we're at any school assembly over at Kirksville High, there's going to be a number of children who are affected by this, or I should say school age, so in various younger grades, but it is somewhere between 3 and 7%. Boys are diagnosed 4 to 9 times as much as girls. Do we remember why that is? Sometimes they present differently. What else?
I was going to say usually the girls have the more inattentive but not hyperactive group.
They
Yeah.
cause less problems so they don't get noticed.
All valid, right? The line outside the principal's office is not often the young lady staring into space, right? It's the boys who are climbing on each other and punching each other as they sit there. So I have one of those at home. He's 14 now. So so the range is, the male to female prevalence. Hello, friends. Thank you for bringing me lunch. So originally it was estimated it was about 3 to 1 in terms of the boys to girls who are affected. But it's actually more likely 1 to 1 when we are able to isolate and take a look and actually do testing. We realize that it's probably about the same, but again, the girls are not as frequently noticed. We're talking about squirrels, by the way, if that helps to catch people up. So because of that, if we're looking at the adult population, does ADHD go away? Do we age out of it? Some may or may not age out of it. They might just find themselves in roles where they don't need to sit in the classroom and stay still quite as much. right? Or they might learn better coping mechanisms. Perhaps they find social ways to adapt and deal with those things. But somewhere between, if we're looking at this, somewhere between, we'll say 5% or so of adults, 5 to 10% may or may not be affected by this. So what's all involved with this? And usually when I start talking about attention is when people have a hard time paying attention. So let's practice that. So if we think about the cognitive process of attention, it's more than just listen, right? In order to attend, in order for you to take anything I've spoken about today and remember it an hour from now, it's going to involve focusing, processing, sustaining that attention, midway through your curly fries, right? It's going to involve inhibiting, shifting to other things like, our devices or our notes or thinking about the patient that we need to see later today. And then organizing some type of response. Maybe it's filing it away for later. Maybe it's pulling up that QR code and looking at the slides later if you need them, or if you're like me and you just, hoard PDFs and articles never to look at them again later. Anybody do that? Yeah. Thank goodness for cloud storage, right? If I was still using floppy disk, there's no way I'd have my PDF game like it is now. So it's really all about executive function. Can anyone give me sort of a definition you'd give to a first-year med student of what executive function is? What I thought. It's kind of hard to define. The way that I will describe executive function is it's the cognitive ability to carry out sequential tasks in a meaningful way. So it's the ability to connect A to B to C to form some type of meaningful activity, meaningful purpose. So it involves, I'm not going to spend a ton of time here, other than to say that it involves our working memory, motor control, our emotions, motivation, planning, and it's found really throughout the brain. We think about it as a very highly evolved thing. It's very prefrontal, frontal lobe sort of organization. But it also requires coordination through our basal ganglia, through the cerebellum, as we're sort of doing more high-level processing. And with ADHD, we do see, and I'll show you some of this, measurable ways in which people who do have ADHD process things a little bit differently than people who don't, right? Whether or not we see it as a disorder, all the feelings that we have about it doesn't necessarily change the neurological underpinnings of what's going on. So I want to talk a little bit about things that we've measured throughout human development. We notice that infants who are later diagnosed with ADHD are actually even more active in utero, which is kind of adorable and kind of painful for mom. They might have more sleeping and feeding difficulties, more colic and crying, more difficult temperaments. Are my OPP people already thinking about ways you might adjust that? Yeah. It's associated with maternal nicotine and alcohol use, low birth weight, brain injuries in utero, number of different things. Preschool, we start seeing when we have the onset, this is the hyperactive or combined type H and C there respectively. But this is when we start seeing kids getting a little bit squirrely, difficulty sitting, being still, temper tantrums, right? Emotional regulation is involved too. It's not just a concentration thing. Parents often find they need to make adjustments at home. And we might be talking about these in clinic. My kid's ripping up the house, or they got into the situation that was totally unsafe and they needed to make some type of adjustment because of that. These are also kids who sometimes have trouble with going to after school programs, getting kicked out. It becomes really something that's very difficult. You can tell my age with the Daria comic here, but school age kids that we spoke about, that's when we start worrying more about learning and academic problems, right? Your preschooler who wasn't doing a great job getting basic, putting letters together to form words and forming those key behaviors, they continue to have problems and they sort of mushroom and snowball as the child progresses. In adolescence, they're going to have poor attention and impulse control. Many are associated with high school dropouts. And here's where the public health case comes in that's kind of interesting. Increased risk for car accidents, substance use, juvenile delinquency, and recidivism. And a number, I was surprised to see this statistic, that a number of children, a significant percentage, up to 25%, the 35 I saw in one paper, of children with ADHD may be involved with juvenile justice at some point. So that's fairly profound. The number here is significantly more for children who don't receive some type of treatment and don't have these things addressed, either pharmacologically or non-pharmacologically. We'll talk a little bit about that. So part of the case here is we're not necessarily doing favors by not treating it, and we're not necessarily doing favors by over-treating it if it doesn't exist. right? So there's a whole wide range of things to talk about here. Now in adulthood, anybody have that friend who just always forgets to call you back? It's not you, it might be you, I don't know, who am I to judge? But, but in adulthood, this is somebody who then has often difficulties. There they are, they just got back to us. With attention, impulsivity, organization, but not necessarily hyperactivity. We notice that most adults, they might be able to sit in the lobby while they're getting their oil changed, but they're kind of looking around, they don't get the thing done, they forget to run the errand after that. We do see they're more likely to quit jobs, more likely to be seen as less capable by their employers. There's an increased risk for some of the things that were in our differential diagnosis: depression, suicide, and problems with social adjustment. So what causes ADHD? Some of the background's here on the slide. You have to look at that, but if you were to put in your own words, what sort of things cause it? If we were to blame it on something, what would it be?
Somatic dysfunction.
Somatic dysfunction. I think that's absolutely fair game. I don't think you're being facetious in saying that, right? So what sort of somatic dysfunctions could be associated with the pathway of ADHD? Yeah, makes sense, right? So this is something that's kind of interesting, a brief tangent here. Where are most of the neurotransmitters in our body? Where are they produced?
Yes.
The gut, right? So if you have a kid who has digestive problems and they have some other type of inflammation going on in the gut, is it reasonable to think that perhaps downstream that affects them behaviorally? I think so. I see it often. I think that actually pediatric medicine is a lot like geriatric medicine, right? If you can get everybody pooping and sleeping, they're probably going to do a lot better, right? And as a psychiatrist, that's something that I think about a whole lot. Yeah.
I used to have an integrative practice, and we saw a lot of kids with ADHD, and a lot of them had pretty significant nutritional deficiencies. So iron deficiency, even without anemia, that wasn't caught on a CBC, and then B12 deficiency. And once they started getting it replaced, they were able to do very well in school, from S to A's.
It's wild, isn't it?
It's crazy.
Yeah. For those interested in sort of an integrative approach to this topic, there's a book called Finally Focused, which is by the author's James Greenblatt. And he talks specifically about nutrition and concentration. He's a psychiatrist who's written a lot about that. But it is very interesting because it turns out we saw concentration as complicated, right? As complex. There's many steps with concentration. There's many different areas then that we as the physicians can intervene and help a person. So some of it might be nutrition, some of it might be pooping and sleeping. Some of it might be getting outside and away from the fluorescent lights a little bit. I don't know. There's various evidence bases that we'll get into a little bit, but I like that we're thinking about these things, right? Because the solution is going to be different for everybody, even if that's not the right answer on the complex. So in terms of genetics, I think that it's worth pointing out that I'll be brief here because nobody wants to hear about genetics over lunch for a whole slide, but there are strong genetic ties. And in general, there's certainly things that we see in first degree relatives. Up to about a third of parents will have kids with ADHD when they have children. Very common in twins. And we do see, as we look at some of the molecular basis, certainly, yeah, there are SNPs, there are polymorphisms, right, on the ways that our bodies process dopamine, norepinephrine, some of the things we can measure. It's not the whole story, but it's fun to have something we can measure and something we can hang our hat on to say, okay, this isn't just a kid who's misbehaving. There's something different about the kid who's climbing on, up the wall than the one who's sitting and staring into space and the one who's paying attention, right? Every single one of those kids or adults has something a little bit different going on. There's more information in the slide set on genetics. You can take a look if you want. It wouldn't be a psychiatrist talk without putting one of these images on screen for you to kind of glaze over a little bit. So I do just want to remind you, again, if you have exams coming up in your future, about the different dopamine pathways, which we often learn about in psychiatry in terms of affecting ourselves for how, say, like our antipsychotics work, and then also the side effects that happen from those, as well as the noradrenergic pathways. So as I mentioned, it's not just something that goes on with executive function. Over here in, let me see if I can use my laser pointer on here. We're gonna be fancy. There we go. Yeah, yeah, okay. So it's not just a frontal and prefrontal thing. as we often think about with executive function, but it's something that can affect any part of the brain. So you might have a child who has ADHD or an adult, and you happen to notice that they're kind of clumsy too. They're kind of dropping things and tripping on things. Where might that be? It might be more of a cerebellar problem. You see what I'm getting at? So these pathways really, they're not, and we focus on the brain, it's a lot of different places as well. So that brings us, of course, then to look at imaging, right? And imaging is, we don't have any radiologists in here, I don't think. No, too bright. Okay. So imaging is fun in my field in psychiatry because it gives validity to things. If we can see it, if we can measure it, it must be real, right? So what we've seen on imaging is that people with ADHD versus controls have different asymmetries in specific structures, and you can extrapolate and think about what these structures do. So especially the left caudate, smaller white matter volume in the right frontal lobe, decreased area in the volume of places in the brain responsible for dopamine receptors, decreases in cerebellar volume, right? There's all these changes again that we can measure in people with ADHD versus controls, which I think is really interesting. I doubt this came up in like the second year psych course, right? And we learned about just DSM criteria. So it's kind of fun to see, hey, these are some of the ways that we measure it. For me, where things get really interesting is when we start looking at Spec studies and PET. What's the difference between those and just like an MRI? Med student question. What do we know about Spec and PET versus, say, just structural MRI? Just the activity in the brain. What's your name? Yeah. Was it? Yeah. Excellent. Thank you. Thanks for answering. So yeah, we're looking at function. We're looking at activity in the brain. So a little bit different than just seeing what's there, but we're seeing how it works. And so what we see is changes in the frontal lobes, actually more profound differences in females. We see EEG changes where there's increased theta waves during concentration in frontal lobes. Number of different things that we see. I'll show you some of these pictures here in a minute. But it's fascinating, right? We can see it on EEG. What does EEG measure? Or electroencephalograms? Brain waves. Yeah, I should have worn out EEG socks, but I forgot to pack those for this trip. But they're another way of looking at brain activity. When we're asleep, we have certain EEG patterns. When we're awake, paying attention, we have certain EEG patterns. If you guys get a chance to observe an EEG or have one done, they're pretty cool to see the way that you can measure things. So one of the other things that we did is these are a number of different studies, and this slide is dated for a bit. I've been using it for a while, but these are in the lighter shade. It's looking at ADHD brain volumes versus those on the right of controls, and we notice that brain volumes in general are a little bit smaller. Does that mean the person is inferior in any way? Absolutely not. It's just a difference, right? It's a different type of brain. I promised some Spec scans, right? Spec looks at activity. What part of the brain is that looking at? I know it can be a little like, what's going on here? Yeah, so exactly, yeah. It's kind of the same way that we would look often at a similar CT or MRI. So I can give you a little bit of help here, right? So this is posterior, anterior, right? So what parts of the brain might be identified here if we're looking up at it? Yeah, so yeah, so we're looking at frontal areas here, right? And this is really cool. So the author on this, and he's got a number of YouTube videos. This is from Dr. Dan Amen, A-M-E-N, where they do Spec studies on patients with ADHD and controls, of course. One of the other things they do that's cool is they will give the same patient methylphenidate and see what happens. And you see these areas that don't have any activity fill in, which is really cool, being able to see that in real time. So again, things are processed a little bit differently. We do have the belief and understanding to at least see the structural basis for this. Now, we mentioned the comorbidities, right? That was in the questions. So oppositional defiant disorder, that's the one that shows up on exams in terms of being incredibly common. Conduct disorder, you remember needing to differentiate between those. Mood disorders, anxiety disorders, learning disorders, those are all common, right? But again, ODD, oppositional defiant disorder, is your test question thing you need to know. Now let's talk about that public health case again. So people with ADHD have all these different things that have been measured. And these are just some of the things that have been pointed out. Again, higher risk in those who don't have treatment for it. Earlier age of first intercourse, more unintended teenage pregnancies, 4 times higher incidence of sexually transmitted diseases, more motor vehicle accidents, traffic tickets, greater use of medical services, especially ERs. Think about that. That can be your study that you do next time you're in the ER here. Do you have ADHD? As they don't, get your attending's blessing. More arrests, more convictions, substance use disorders, high rates in prisoners. And this is interesting, is that treatment of ADHD in a population on parole and probation resulted in fewer violations and earlier parole, which I think is really interesting. So again, another case for perhaps recognizing it when it's, when it's there and doing it. So the reasons that we treat it are for all these different things, right? It's not just a matter of focus. It's not a matter of convenience. It's all these different, really, I think, kind of public health reasons why we should pay attention to it, be aware that it exists, and think about it. So, quick squirrel break. Questions about what we've spoken about so far? Has anybody learned something so far today? Okay, so that's good. That's the goal, but that requires executive function, right, and concentration. That can be really hard to do over lunch. So I applaud you guys for doing that. Now let's go back to our patients. 33-year-old male, no past medical history, presented in clinic with a chief complaint of difficulty concentrating. What might lead you to think about ADHD versus any of the other 100 things on the differential?
We have a history of struggling in school.
Ah, okay. History of struggling in school. Next level question, med student question, is you're taking this history, what's an open-ended question you could ask to find out that information? Yeah, when it started. Yeah, I'll often ask folks, tell me what was school like for you? What were your friend groups like? What was it like to study for exams? How were your grades? Right? These are some different ways that we can get to that information in the most broad sense possible. And they might tell you everything was fine. And that gives you a different idea than, oh man, I was in trouble a lot, or I dropped out, or any number of things that you can get. So adult ADHD is still in many categories considered controversial, right? I didn't get asked to talk today about mathematics disorder in 7-year-olds. Not that controversial. But adult ADHD is still regarded as controversial despite it continuing in so many of the people who grow up who had it as kids. Again, the diagnosis is primarily clinical. And I like to say that the DSM is really only partially useful here, because the DSM is really focused on kids. It's really focused on, it got a little bit better with DSM-5 saying these symptoms had to be present before age 12. It used to be earlier. But the adult diagnosis can sometimes be a little bit more complex. Number of shortcomings for adults, right? Somebody as an adult can be functioning pretty well in their overall community. They might be doing just fine in whatever it is they're doing. Maybe they are a ranger over 1,000 hills and they have to drive around all day and go exploring and, be active. But maybe they're impacted in their home life or something, right? So there's all these different kind of shortcomings that can come. It's interesting to ask about financial management, right? Are you able to manage a budget? Are you, what are your finances like? What's these things that adults do that kids don't do? So our question set changes a little bit. Might be, how are your relationships? When your, spouse, partner, whomever gets mad at you, what sort of things do they get upset with you about? Cleanliness, right? My husband or wife is always harping on me because I'm losing stuff. Or I never, everything's all cluttered. Things show up in different ways than they do in kids. So again, DSM is only partially useful, I think, but you still need to think about it. That question?
You have no prior history before.
Great question. Is that a question or? Yeah. Okay. So sometimes, right? Because sometimes you'll have somebody who comes in a clinic and says, you know, hey, I was treated for this as a kid. I haven't been treated in 15 years. Doc, help me with this. Or you have somebody who comes in and it's brand new for them. Or you have somebody who's, you know, they moved up here from Rolla. They had a doctor who was treating them. Now they're a student at Truman State and they need a new doctor to help them. And they've been out of meds for a month. So there's a whole wide range of it. But it's interesting because the controversial part applies to those who continue it. A lot of physicians still believe patient will just grow out of it. Or they'll think that, well, you've been doing fine for 5-10 years, why now? And the answers to that are not always easy to figure out. Maybe it is somatic dysfunction, right? I'm a fan of that. I did get several PubMed hits when I was preparing for this, looking at osteopathic medicine or osteopathic approaches to ADHD, which shouldn't surprise anybody who's been here and thinks about that. So diagnostic considerations in adults. This is something that I think is important when you do have either the new onset or recurring onset adult patient. Ruling out underlying conditions, right? We talked about thyroid. We talked about substance use. We talked about sleep apnea. DSM-5 is just one box on my list, right? We'll talk about the ASRS here in just a minute. So if you don't know what that is, stay tuned. I wrote a family history of sudden death. Why might we want to know about that?
Oh, yeah.
Yeah?
Any arrhythmias or any issues with their heart.
Mm-hmm.
I think there was some studies on the ADHD meds with an increase in hypertension and
Yeah.
something else. Increased heart rate.
All those things, right? Anybody drinking a caffeinated beverage? I see a Mountain Dew over there that's gone. I see a Coke that's also empty. Smart water guys, you're cool. So, right, stimulants are going to have cardiovascular effects. We know that from first year physiology stuff, right? And if our primary treatment is a stimulant, there is we do want to find out if somebody has a history of cardiac sudden death or like AV malformation, structural changes in their heart, especially if we're thinking about stimulants. Your initial history is a good time to find that out. Why do I say you don't diagnose ADHD by medication trial? I'm just going to give you some Adderall and see if it works.
Because Adderall helps everybody.
Yeah.
Nailed it. Nailed it. Any one of us would have an improvement in our performance for a little bit, and maybe some problems, but at least some improvement in some of our performance if we took a stimulant. Right? That's not to say that everyone in this room would meet criteria for ADHD, or maybe we would, I don't know, but that's not how we figure it out. Right? This was something that I remember my program director from residency really harping on us about was we're all going to get a little bit better with the stimulant if that's what we need to do. So a lot of things to keep in mind here. The ASRS, I apologize, I know that's tiny, but again, it's in my slides, which are available, the QR code or the website if you want. This is one way that you can diagnose ADHD. Let me rephrase that you can help your diagnosis of ADHD or not ADHD in adults. The problem is it's a self-rating scale. So somebody who's coming in and seeking stimulants for whatever reason, they may be able to process this with an adult mind and be able to understand it. So this is freely available online. For board purposes, what are the scales that we use in kids? Vanderbilt, Connors, those are the top two, right? Connors is considered more proprietary, but still shows up on exams. Vanderbilt, Connors, less useful in adults because you're looking at the Vanderbilt scale and it's like, take this form to your teacher to fill out. And your Walmart employee's like, all right. You know, so something to think about. This is just one tool that you have in addition to the things that we spoke about. Treatments. This is where we start diving into the resident-ish side of this. Is that stimulants, even though they're not perfect and they're a pain to write and deal with the pharmacies and the national shortages and all the different things going on, they're still considered first line. Followed by atomoxetine. We spoke about atomoxetine earlier. What's the mechanism for atomoxetine? Norepinephrine reuptake inhibitor. Good. It's a very bad antidepressant, very medium average thing. Like an antidepressant, though, it's going to take some time to work if you prescribe it for ADHD. So let's say stimulants, I give a patient Adderall. When are they going to notice the effect of that? About 30 minutes. I give them atomoxetine. When are they going to notice the effect of that? About 4 weeks, if they notice it at all, right? It's gradual. So my guidance that I give patients if I'm prescribing atomoxetine is similar to if I'm prescribing any other antidepressant. Where I'll say everybody responds to this differently. You might notice some effect right away. I don't want to rule that out. If placebo is very powerful, right? And also some of the physiologic changes that is measurable immediately. But we think most patients, the best effect you're going to get from this is going to continue to build over the next 2, 4, 6 weeks. Okay, so I don't tell them nothing's going to happen until 4 weeks. I leave it open. Bupropion, what's the mechanism for that one? Dopamine and norepinephrine. Yeah, good. Who knew we were going to get a little board review, right? Sorry. Okay, so bupropion is considered second line. Something we can absolutely consider in a patient who has comorbid depression and concentration issues, right? Who learned SIGI CAPS as part of your depression screening? What does the C stand for? Concentration, right? So that's another one of the comorbidities I think was mentioned over here. Was it meta?
Yeah,
Okay, that's okay. So it wasn't Ming. Ming had something, but anyway, it wasn't Ming. It was that table. But you guys were like, well, depression can cause issues with concentration. Absolutely. And if you're not sure, and there's no alcohol use disorder, seizure disorder, electrolyte abnormalities, or issues with headaches, bupropion is a reasonable place to go, or Wellbutrin. There's evidence for tricyclics, but we really don't use them given all the problems with tricyclics unless there's some reason that we also want to have a tricyclic. Migraine headaches, if you need it for sleep, if they're on that level of their depression treatment. Guanfacine, do we know about guanfacine? And we know clonidine, right? So these are medications that work on the alpha system, so our alpha-2 agonists. Modafinil we don't use, but it's worth talking about.
We treat with behavior therapy for
Love the question. So if you're looking at most psychiatric disorders, let me zoom out here just a little bit. And you have to choose between meds, therapy, or meds and therapy. What's usually the right answer? Meds and therapy. ADHD is interesting because if you try to have somebody who can't focus and you're putting them in, for kids, behavioral therapy is great. For adults, let's say you try to put them in a cognitive behavioral therapy, they often can't cognate well enough if they're coming to you with this in order to get the skills. So ADHD is one of the few things where actually the effect size of medication is considered more than therapy, at least until they have the ability to attend. Now, that's not to say that therapy isn't, there's so many other places that it can be useful, right? It can help with relationships, it can help with coping skills, it can help perhaps with concentration and study skills, but it's going to be a little bit different than if you have somebody who's really where the issue is the cognition, right? If we go back to that Spec scan, we do have evidence that yes, therapy can absolutely help with neuroplasticity, help to change, the way that we behave changes our brains. It just does the way that we move our bodies, changes our bodies. But you may often, for test purposes, meds are considered first line. That was a longer response than I wanted, but I wanted to give some of the context for it, right? Because I am a huge advocate for therapy. But my patient, for example, with severe schizophrenia, I'm not going to send to therapy until they're on the antipsychotic. My patient with severe ADHD, I may or may not send for therapy, depending on how much they can learn, right? How much they're capable of it. There's some good evidence for omega-3s, just in general. Things like telling the patient to, well, go have a double espresso, go have the yerba mate. Not a ton of evidence for that. St. John's wort is primarily serotonergic. You might have had that come up on board exams, kind of. I think it grows around here, too. Anyway, pretty little yellow flowers. Don't try that when you're out of the park, but especially if you're taking other meds. So likely ineffective. I do have these tables in the slide set just for your review. Again, the slides are available to you. We're not going to get into the ins and outs of, methylphenidate versus Adderall, these different things. There are algorithms that can be used. Don't you love it when you see something like this? Oh yeah, just use this to make your decision, right? So I have information again about stimulants, benefits, side effects. One of the things that I did want to echo here, though, especially for med students and sort of primary care mindset, is this idea here. This graph, the blue line takes a look at Ritalin or methylphenidate and the 3 times daily dosing. What do we see happening there? We're riding the waves, right? In terms of the plasma concentration. So you've got a kid who's really focused for a couple hours and then drops off a little bit. Then they get their lunch dose. They're really focused for a little bit and then they come down. There are extended release formulations that have been around for a long time, but we're still not often prescribing them. Let's see. So the extended release formulations demonstrated here by the orange line that sort of reaches a plasma concentration plateau and stays there for the most part for up to 10 hours in some cases. Can be a great thing or a terrible thing depending on how it's dosed and used. So it's just something to think about. Or if you do have somebody who you think could tolerate the medication, sometimes starting with the extended release is reasonable. I have some information on atomoxetine or Strattera. I know we spoke a little bit about that. Then there are the 2 alpha agents, guanfacine and clonidine. Again, not going to spend a ton of time here, but when might we use those agents instead of a stimulant, instead of Strattera?
Take this one.
Take this.
You can't sleep.
Yeah, maybe. Right. Good for more of the hyperactivity symptoms, good for sleep problems, you know, if somebody's hypotensive, those types of things. I think I think the main things that I have left are just different slides for your reference. And maybe I'll pause there because I see it's about that time.
Hey, do you use Bacopa in your practice?
Not yet. Should I?
I don't know, I'm taking it.
Okay.
Great.
Yeah, give me a call. Let's talk about it because I'm curious about it.
Yeah, it helps you focus, but some people get like, it feels like you're on like 6 cups of caffeine when you first start.
Oh, okay. That's
it like tapers down after a week.
That's significant. So 6 cups of caffeine is a lot.
Well, it was like, and then.
And don't mind what's going on here.
So I don't know, seems like it's helping. Maybe it's psychological.
That's cool though. I'm
Yeah.
excited to hear that.
I mean, I don't really need it, but I was like, maybe I need to stay at these lectures. You know, a lot of lectures.
You do. I'm sorry to add to that burden.
No, it's
Yeah.
great.
Thank you. I'm going back to the QR code for the folks who came in a little bit later, just so if you do need the slides for your reference, you can go ahead and download those. I had to put it back toward the end. So if you do need that, if you came in later, if you need QR codes, they're also up on my website at the KCOM ADHD slide of things. But I appreciate everybody's participation and interest in this very fun topic. Any questions or discussion?
In prescribing extended release stimulants, I think the main reason I don't typically do those first is insurance coverage. Do you have any recommendations? Like, is there a way to start those first and get insurance to cover them?
It's really tough. Yeah, it can be tough. If it's something you see a lot of in your practice and there is one insurance that you're working with more than the others, sometimes I'll just try to talk, believe it or not, I'll try to talk to the medical reviewer, the medical director, and just say, what's the best thing I can do for my patients in this situation? It ends up being more cost effective for them if they have a relationship with the doctor and they understand it. So sometimes it's a formulary thing, sometimes it's a formulary exception of just kind of having, you know, that flag on there. But again, it can very much depend. So, but sometimes it's a great point. You do have to start with the short duration ones, right, and then show it's not lasting long enough, and then do the prior authorization. But so much work, especially when the generics are, you know, Concerto's pretty cheap right now, and that's an ADR. So, yeah, I wish I had a better answer. Yeah. Other stuff. No. All right. Dr. Thomas, anything you want to make sure we got to that we didn't? No? All right. If this topic is really interesting to you, and for whatever reason, we're doing another talk at 5 o'clock that's more med student focused, that looks more at coping behaviors. It's got some osteopathic considerations. It's got some overlap for the things that I think are cool, like the neuroimaging. But that's where's that happening? Do you know where? Oh, okay. So, yeah. Okay. Very good. All right. So thanks for attending. I'll hang out for a bit if folks do want questions or whatever.
Thank you very much.
Thank you.